Hello everyone. First and foremost, I would like to thank the KREST team, including Dr. Kavita, Dr. Vijay Bhaskar, and Dr. Ishwar, for inviting me to give this talk. Life and career as a radiologist in the United Kingdom. Kavita has introduced me, but I would like to just give a brief overview of my journey. I started off my radiology training in India, in Andhra Medical College, Visakhapatnam. That is the building you see on the right top there. Once I finished my MD radio diagnosis there, I went on to do my senior residency in NIMS, Hyderabad for a couple of years. And after finishing that, I moved to the United Kingdom, where I did my radiology training, which is called the Specialist Registrar Training in Hamstel Hospitals, London. And through this training, I obtained along this training, midway, I obtained my FRCR. On completion of my training, I became a consultant radiologist, and I've been a consultant for the last 20 and odd years. I also got involved in other activities, and most importantly with the British Institute of Radiology, and over the last 14 years I've done various roles for the FBIR, leading up to my presidency, which I started exactly a year back. As you can see from the buildings on the right, there are some similarities between the top, which is the King George Hospital in Visakhapatnam, and the bottom building, which is Hammersmith Hospital in London. Well, apart from the color of the bricks, there's some design similarities. Obviously, the KGH in Visakhapatnam was built by the British early on. Coming to the training itself, there are some similarities, but some differences as well. And both have their pros and cons. And I was lucky enough to taste both. My Indian training, my degree there was called Diagnostic Radiology. I would say it gave me a strong basic foundation in radiology. And also, I moved to Nizams afterwards, as I mentioned earlier, and that taught me to cope with high volume of work. It was a very busy hospital. And the senior residency I had at NIMS was a stepping stone for my future career. That's how I look at it. My initial mentor at Visakhapatnam was Dr. Vijay Bhaskar, who is on this webinar today, one of the organizers. And in Nizams, I had the four pillars: Professor Ramurthy, Dr. Jagan, Dr. Bhaskar, and Dr. Ganapati, Surya Ganapati. All of them played a big role in my initial career progression. And obviously, I had excellent colleagues, contemporaries like Dr. Kavita, Dr. Hema, Dr. Josna, and many others actually. We had great fun doing our training over there. Then I said I moved to UK, and the emphasis was slightly different there. Their radiology was called clinical radiology. So it was more structured training, I would say. Some of the things I had to unlearn and relearn again, which is a good thing in a way, looking back. And there is lots of clinical emphasis. And it's not about volume, it's more about the quality. Yes, we give good quality in India as well, but here it's not about the volume. That's one thing I learned. In fact, looking back at my interview for my first clinical post in Hamstel Hospitals, one of the questions was about my work and what I did in India and the workload. And I remember answering one of the questions saying, ultrasounds, for example. I mean, what is your typical work in ultrasound back in India? And I said, I do around 30-35 cases a day, which was what I used to do in Nizams. They were a bit taken aback, actually. I'm probably a bit shocked. And I had a feedback after the interview saying, even if you do so many, don't say that number. Doesn't sound good that you're rushing through, in other words. So I learned a lesson there, actually. Anyway, going back to the UK training, yeah, it was a more structured training. It's a 5-year program and covers a wide range of subspecialties, and you can actually choose in your last 4th or 5th year what you want to do, your area of interest. I'll go into more detail later in my talk, but the bottom line is I had the best of both worlds by training both in India and the UK. Now, coming to the actual talk itself, my talk I'm going to divide into different parts. I mean, initially I will talk about the NHS as in general, the National Health Service in the UK, which is unique. I'll talk about just a brief background of the NHS. Then I'll go on to the radiology training for people who start training in the UK or people who train in India and moving to the UK. I'll cover both aspects and what are the methods or routes to come to UK if you want to come. Then I'll give a description of the radiology departments, how they work in UK, and finish off my talk by briefly talking about life in the UK. As I said, there are no rights or wrongs. Both systems have pros and cons. So coming to the NHS, as of 2019 October, there are 223 trusts across England. Sorry, UK has 4 different parts, as you know: England, Scotland, Wales, and Northern Ireland, and all have slightly different health systems. Some variations between the 4 parts of UK. In England, there are 223 trusts, and each trust can have multiple hospitals. On average, 2 or 3 hospitals in some parts of the country, because and each trust covers around, the population can vary between 300,000 to up to 1 million, depends on the area. And as I said, each trust can have more than 1 hospital. So there are in England more than 500 hospitals. Don't know the exact number. These trusts can be acute trusts, which provide emergency services, maternity services, the core surgical medical specialties, pediatrics, and obviously radiology. Then you have specialist trusts or tertiary centers. These can be specialists to one specialty, like orthopedics, Royal National Orthopedic Hospital in London, or the Queen Square Neuro Center, or you can have tertiary centers like NIMS, where you provide a range of specialist services. Then you have mental health trusts, purely, obviously the name implies, says it all, and finally community trusts as well. So there are all these come under the NHS. And NHS was established in 1948 with a budget of £437 million. This is for patient care, basically. And this is roughly 9 billion at today's value. This is a health service that's supposed to treat the rich and poor alike. Poverty is not a disability, and the wealthy are not advantaged. In other words, everyone is treated equally. It was set up as a tripartite system. You have the primary care, or what we call the general practitioners. So all of us have to register with primary care, with the local GP surgery. That's what we call them, GP surgeries. Then for anything, we approach them first. All the basic illnesses are treated by them. Anything they can't deal, or anything more specialist, they refer to the next level, which I'll come to in a minute. In between the primary care and the hospital services, we have community services. So things like maternity, child welfare, midwifery service, health visitors for example, vaccination, etc., immunization, health education, and ambulance services. All of these come under community services. They are in the middle. Then you have the hospital services, which provide the secondary and tertiary care, which I mentioned earlier to you. So it's a tripartite system, and it has modified over the years since 1948, but the basic tripartite system has stayed. The names have changed, the personnel have changed, but the basic system still remains. Coming to the present day NHS. NHS has completed 70 years in 2018. For 2018, the budget has increased to 2018-19, increased to £114 billion, which is in Indian rupees 11,66,000 crores. That is almost 10% of the GDP, which is £2,000 per person. So this is compared to India, for example, where the budget is, if I'm right, 2 to 3% of GDP. It's 5 times more, and we still struggle. In spite of this budget, it's still not enough. So NHS is the biggest employer in Europe with more than 1.1 million, 11 lakh employees. 60% of the budget goes towards the staff, and the other 40% to obviously the drugs, supplies, the equipment, etc. It's a mammoth organization. The future of the NHS, the NHS is changing, as I mentioned, and it's going to be what it's going to be called integrated care systems. The NHS organizations, like the hospitals, are going to work with the local councils. This is to provide what we call horizontal integration between primary care, social services, and community care and secondary care. Everything is going to be linked up. It will be a patient-centered care. What the patient needs. The services should be coordinated around the needs of the person. And the people should receive care and treatment in the right place at the right time. Some of them can be treated in the community. They don't need to come to the hospital. Long-term conditions can be treated locally. Diabetes, you don't need to come to the hospital. So whereas some need specialist services, if they need a surgery for hip and knee replacement, they have to come to the big hospital. So all this is being coordinated. This is in the development process. It's also adopting new care models to meet the changing demographics and healthcare needs. People are living longer. People with cancer are living longer. So once you treat them, they have regular follow-ups. All this can be done in the community. It's called stratified care pathways. So as long as stratified care is given to a patient, then can be followed up afterwards in the community. Now, coming to the radiology workforce. According to the 2020 RCR census, which is the last census we have, there are around 4,000 consultant radiologists in the country. But with a big shortage as well, around 33% of the posts are still unfilled or filled by locums or temporary work staff. But the forecast for 2025 looks even bleaker. We need lots more radiologists in the next few years to cope with the increasing demand of the specialty. So in 2025, we expect to have 4,600 radiologists in posts approximately, but with a big shortage of 44%. We have around 1,760 trainees in UK currently. Year on year, they have been increasing. For example, this year we had an additional 100 new training posts. That means, on average, around 300 new radiologists are coming out of the system every year. This is not enough. It will take many more years to meet the increasing demand and the shortage of radiologists. There are many unfilled vacancy posts. The vacancies reported are actually an underestimate, because if we can at any department, we need lots more radiologists for the work we do. And so because we know that we can't fill these posts, some of these posts are not even advertised. Over the past 4 years, approximately 50% of the posts remain unfilled. And in fact, 6 in 10 posts have remained unfilled for 12 months or more. Because this is simply because there's been an exponential increase in the imaging and technology, and leading to need for more radiologists to report all these studies. The number of UK trusts who are attempting overseas recruitment has also increased steadily over the years. And as of 2020, over 100 trusts, that's around 60%, have gone for overseas recruitment. Some successful, some not so. And you know what, in 2020, last year, a third of consultant radiologists working in the UK were international medical graduates. And just over a third of these, only a third of these undertook specialist training in the UK, people like me, for example. In other words, 2/3 actually had the training in other countries and came to UK to work. Obviously, where is this demand coming from? There is increasing demand for complex imaging in recent years, as you all know. We have nice guidelines here, which are guidelines given to us and we have to follow. They have scientific evidence, evidence-based medicine. Because of that, there's huge increase in the number of CT cardiac angios they're doing. Previously, they used to do conventional angio, coronary angios, but many of these patients are now having a CT cardiac angio, and then they go on to have further interventions if necessary. CT colons, another big part of our work here in the UK. Many of the patients have a CT colon instead of an optical colonoscopy, particularly the above 80-year-olds with high morbidity, people who can't have a colonoscopy for other reasons, for other comorbidities, and people who have a failed colonoscopy. These are the 3 main groups. And in fact, every week, for example, in my department, we do around 3 to 4 CT colon lists, 2 to 3 CT cardiac lists, a big increase in the numbers in the recent years. And over the last 5 years, we have seen a 54% increase in the number of CTs we do, and 48% increase in the number of MRs we do. Plain radiographs and ultrasound has remained static, more or less, though ultrasound has seen a slight increase, but not so much as CT/MR. There has been a fall in fluoroscopy cases because we do less and less. In fact, hardly any bariums, for example, hardly any barium enemas. For example, we do just CT colons. We stop doing barium enemas. Barium swallows and barium meals we still do, but number of fluoro cases have gone down dramatically. But there is an increasing demand for interventional radiology across all subspecialties. Coming to the growth in these specialist areas, the largest proportionate growth we have seen in the UK is in musculoskeletal radiology and gastrointestinal radiology. What I mean by this is the number of radiologists doing training in these 2 areas has increased dramatically in the last 10 years or so. But the specialties which were taken up the least were breast and interventional. There is a growth, yes, but not so much as we want it to. There are some new areas which have come up, specialist areas which come up in radiology. One is pediatric interventional radiology, which is a new growing specialty. And also imaging, IT, and AI, artificial intelligence, is another area. People are taking up this as a special interest, and including me actually. Coming to the interventional radiologists specifically, there is an estimated shortfall of 364 interventional radiologists as of last year's census, equating to a 35% shortfall. This is very important because we need at least a minimum of 6 whole-time equivalent interventional radiologists to provide an effective 24-hour on-call service, IR service. So this is almost impossible for many of the smaller hospitals. So what is happening is people are developing networks to provide a 24/7 service. In other words, say 3 hospitals get together and provide an on-call service across that area. And there is also, clearly because of this, the shortfall in reporting capacity. And how are we managing this diagnostic imaging demand, given that we don't have enough people to report the scans being done? In fact, many hospitals have backlogs in the UK. This is done by various ways. We can't leave the scans unreported. This is done by paying additional sessional money to radiologists. This is called insourcing. So we have a contract, say, for 40 hours for the hospital. We can work longer hours for the weekend and get paid extra. It can be outsourced to independent sector or teleradiology. Anyone who has an FRCR and GMC registration can report them from anywhere in the world. Radiographer reporting. Some radiographers are trained to report plain films, basic MR like MR lumbar spine, MR knees, or a CT brain, for example. So they're trained for a period of time. They're assessed regularly and they can report on their own. Some radiologists do it by goodwill. I mean, if they have additional time in their job plans, meaning in their weekly work, if they finish their work, then they can do some extra work. I mean, as a matter of goodwill. Employing ad hoc locums, meaning locums can come for a few months, clear the backlogs, and go. Some images are not reported. For example, some plain films on ITU, intensive care, who have tubes put in. The ITU consultants can themselves look at those cases and they're all auto-reported. Some reporting is delegated to clinicians. For example, orthopedic follow-up x-rays for fractures. The orthopedics are best placed to look at them anyway because they are well used to them. And they can put a quick report saying satisfactory position of the prosthesis or something like that. Some departments follow that. And finally, developing imaging networks, as I mentioned earlier. So, there is a great opportunity if you want to work in the UK. I'll just briefly talk about the radiology training and application process. Overseas graduates without FRCR, they have to take the PLAB examination, the Professional and Linguistics Assessment Board test. Only then they can start working in the UK. I mean, if you want to do radiology or any other specialty. For UK graduates, following MBBS, they do a 2 years foundation training, which is like our house agency, but spread over 2 years, where they rotate through different specialties. That's a minimum. So maybe MBBS plus 2 years before you enter any clinical specialty. Now, if you decide to go into radiology, or most specialties actually, but if you decide to go into radiology, then you take an exam called MSRA, Multi-Speciality Recruitment Exam, and you get a score for the exam. This exam is formed of 2 parts. The professional dilemma part, or the situational judgment part. They give a scenario where, for example, there's a problem with a colleague, how do you deal with it? So you need to give your opinion on that. Then the second part is the clinical problem solving, more of subject matter. This is in the form of MCQs. Then the top 600 are interviewed. In the interview, following the interview, the MSRA score, the interview performance, and also everyone has a portfolio, so which is assessed and given a score, and all these 3 scores are put together and taken into account in the selection process. Now, one thing is for sure, the demand for radiology is increasing, but also the interest in radiology amongst junior doctors is also increasing, as you can see from this graph. It is an increasingly popular specialty with more and more applications coming through every year, and more steep increase in the last couple of years actually. Because of this, the number of interviews have been capped to 600. So, for example, in 2021, there were 1,677 applicants for 353 radiology training posts. We call it ST1, Specialist Training, Year 1 posts. That's the ratio of 5:1. In fact, a few years back, orthopedics was the most popular specialty, 10:1 ratio, and some other specialties also had quite high ratios. But now, orthopedics has come down to roughly the same as radiology. In other words, radiology is as popular as orthopedics in the UK, just as an example. In fact, this year, the top 55 ranked in the exam, MSR exam, were given direct entry without an interview, and the rest were called for interview for the remaining 300 posts. Once you get selected after this process, all trainees are required to enroll with the RCR, Royal College of Radiologists, and become a training member prior to commencing your training. Trainees are required to maintain this membership throughout their training, and it's a 5-year training program, as I told you. And in the first 3 years, which is called ST1 to ST3, you rotate through various subspecialties. Actually, the first 6 months, you get used to the system. Normally, most rotations, first 6 months, you get used to the system. And then you start going to these various areas: breast, cardiothoracic, gastro, pediatrics, etc. And it's all, as you can see, there are 10 areas to cover, which takes you another 2.5 years. So by the end of year 3, beginning of year 4, you cover all these areas, and you become you get the fairly good understanding of what radiology involves. It's quite a wide specialty. So this is a brief figure to show how the training progresses. So FI1, FI2 is just following your BBS. Then the clinical radiology core training, first 3 years, where you rotate through various specialist areas in radiology itself. Then year 4, year 5. I'll come to that in a minute. So in the first 3 years, you take your exams as well. Sorry about the typo. The FRCR part 1 is taken in year 1. This is a physics and anatomy exam. Then the FRCR 2A covers all the areas they rotate through. This is taken normally in year 3, sometime in year 3, which is a theory exam. Then the Viva part, FRCR 2B, the Viva and practical part, is taken at the end of year 3 or beginning of year 4. So most people tend to complete 2B in year 4, though some people might have some delays in their passing the exam. But generally speaking, most people complete by year 4. This is important because in years 4 and 5, if you complete your exams on time, you have time to develop your specialist skills. In year 4, 60% of the time is dedicated to your honing your general radiology skills, but 40% of the time you can choose a specialist area where you want to develop your skills in. And once you know that's the specialty you want to do, moving forwards, in year 5, you can increase the time in that particular specialist area to 60%. So at the end of year 5, you will have some good competency in that particular area. If you want to go to further training or go for a fellowship in these areas, interventional, neuro, musculoskeletal, and other specialties, people choose a year 6 as well to finish their training or a fellowship year. Throughout this training, there are various ways you learn. The main way is work-based experiential learning, supervised training in other words, but gradual reduction in supervision with increasing competence and confidence. So in years 1, 2, for example, you'll be supervised directly, then year 3 indirect, 4 and 5 more and more you do without supervision. Once you get your FRCR exam, you're allowed to do certain things without supervision, but certain things you still need to be supervised or more indirect supervision. You have formal postgrad teaching sessions, particularly in the first few years. Yeah, in the first year, for example, you have physics and anatomy teaching, direct face-to-face or virtual teaching. Then you have system-based teaching as well. Then you have journal clubs, research audit projects. You need to undertake at least one audit project every year. You have, obviously, independent self-directed learning is always important until you clear your exams. Then you can attend external study courses and conferences. There is a budget for that. You're paid to go to these courses. You learn with your peers. And finally, something I want to mention is the academies we have in the UK. There are 5 academies spread all across UK. These were set up to address the workforce needs a few years back. And here they take a high intake of trainees. In the first couple of years, they have more of lecture room teaching and simulated teaching. This proved to be quite successful. And also, they go on to do the clinical postings as well afterwards, or simultaneously sometimes. But these academies have proven of immense benefit to increase the number of training radiologists in the UK. And throughout these 5 years, the trainees are assessed regularly. Some as frequently as the three monthly modules they have in various areas like specialties like breast, cardiothoracic, and the list I showed you earlier. and they have assessments every 3 months, and some annually. These are the various ways we assess them. And couple of things I want to pick up is, we also it's not just about the subject matter. We also look at the multi-source feedback. For example, they have to send out feedback forms to other members of staff, their colleagues and consultants as well, about the general interaction with patients, with staff, and how they react to situations and all those things. That's also equally important, not just your subject, what you know. You need to have a holistic approach to the whole training program and seeing a patient and treating a patient. And you're also assessed for your radiology direct observation of procedural skills. MDT assessments, we have MDTs, which I'll come to afterwards. And at the end of each year, you have your annual review, called the ARCP process, annual review of competency progression. So every year you're signed off saying that you have finished your what you're required to do in this year 1, year 2, year 3, etc. And at the end of year 5, once you have finished all your training and you get your exams as well along the way, you get your CCT, which is called the Certification of Completion of Training, following which you apply to the GMC to enter onto the specialist register. And once you are on the specialist register, you can apply to consultant jobs. So that's how it works, the whole process. It's a very structured, systematic training process, at the end of which you get the certificate to enter onto the specialist register. What about people who already have their FRCR from overseas? As nowadays, you know that you can take your FRCR overseas. India also has a center, thanks to Apollo Hospitals. Dr. Raju Kalidindi has successfully managed to get the FRCR exam to India. And it's okay. If you get your FRCR outside the UK, what is the process? Once you get a FRCR, you apply to the General Medical Council in the UK with all the relevant certificates. Simultaneously, you also upload these onto the EPIC platform for verification. That's the electronic portfolio of international credentials. You also need to take the English language test. Most people take the IELTS, International English Language Testing System, and some take the OET, the Occupational English Test. That's compulsory to come to the UK. And once the GMC is satisfied with all the credentials and the certificates verification, it issues a license to practice. Then you can apply for the jobs directly. This you can do by looking up the British Medical Journal. There's a BMJ jobs section which comes up with the vacancies, and you can apply directly to those trusts. And you can also apply through the local agencies. Some of them are in India itself and some in the UK. You can register with them and apply through them. Or you can also find out through contacts in the UK if there are any vacancies, and then apply if there are vacancies. So this is one way. But there is another scheme which has come up in the last couple of years, 2-3 years back, the Global Clinical Fellowship Scheme, which is for post-FRCR overseas graduates from India. This is a joint initiative from, by Health Education England and the Royal College of Radiologists. And the Indian partner is Apollo Hospitals, Apollo Radiology International, led by Dr. Raju Kalidindi. It is a 3-year program. The placement is in selected trusts who have shown an interest to take up these global fellows. And in fact, our trust is one, and we have one global fellow in our trust. So I have first-hand experience of how this works. The first cohort came a couple of years back. There is provision of subspecialist training by direct supervision. So the way it works is they're employed by after the necessary interviews and checks. They are employed by the respective trusts, and the job is a 10-session job or a 5-day job, out of which 6 are service sessions. You do what the trust needs, but 4 are dedicated to your area of interest. So when you come and join this trust, or even in fact, even before you when you apply for these posts, you mention what specialist areas you would like to get trained in, be it MSK, GI, head and neck, neuro, whatever. Then they are posted to a trust which can offer that particular training. So 4 of the sessions or 2 days in the week will be dedicated to that particular specialist interest of yours. You are paid at middle grade or junior consultant level. You will have on-call commitment, not straight away, but once you get to know the system and once you're comfortable with dealing with acute work, answering the clinicians, and etc., you will be put on the on-call rota as well. You will have good peer support and guidance from your fellow colleagues. And it's a mutually beneficial arrangement. It is good for the trusts who have lots of vacancies and who are struggling to recruit in the UK. It's also good for you because you will develop your own specialist area of interest. So at the end of 3 years, you have an option of going back to India, coming back to India, or while you're here, you can also apply for the CSER, which is Certificate of Eligibility for Specialist Registration, equivalent to the CCT I mentioned earlier. So you apply for a CSER. The CSER you need to get onto the specialist register in the, on the JMC specialist register, and this is if you want to settle down in the UK in a long-term basis, or in other words, apply for a consultant job. You need this. This is a long process. I mean, it takes around up to a year to get this. So you need to start this process sooner rather than later. And in fact, you need to start, if you plan to come to the UK and settle here, best to find out what you need from the college, so that you can start your preparation while in India itself. Now coming to the radiology services in the UK. Radiology services are provided both in tertiary teaching hospitals and also in the district general hospitals or the DJs. I mean, anywhere, radiology is a big department. The tertiary teaching hospitals are specialist referral centers. And I mentioned to you earlier, they can be dedicated to one specialist area of interest, like orthopedics, neuro, etc., or can have a wide range of specialties. Most of the radiologists there have some form of fellowship, and most of these centers are attached to a university. For example, Edinburgh Hospital is attached to Cambridge University, whereas Guy St Thomas's in London attached to King's College, London. So these are university affiliated. So because of that, you can take up academic research posts as well in these hospitals. Coming to the district general hospitals, they are also quite big. They cater to a population ranging from 300,000 to 1 million on average. They provide secondary care, so they are big enough hospitals. When to draw a corollary, I mean, for example, King George Hospital in Visakhapatnam or Osmania Hospital in Hyderabad, they are secondary care centers. Even though in India we call them tertiary care, they're secondary care centers. I mean, the DJs in UK are similar to those hospitals, though slightly smaller in size. They have all the emergency and elective, they can have all the departments like accident emergency, or most of the medical surgical specialties, maternity pediatrics, radiology, etc. They provide both emergency and elective care. But to work in these hospitals, you need to be a general radiologist, but with an area of interest. So most of us have 1 or 2 areas of interest. For example, I trained in musculoskeletal radiology and GI radiology. So I cover general aspects, but also do those two as my area of interest. More recently, some of these trusts have been merging, and so you can have a joint job across hospitals. So if 2 hospitals are merged with a common management structure, those 2 hospitals will still be functioning, but radiologists are appointed jointly, so you can have sessions in both the hospitals. Some DJs can be split into various sites. You can have a main acute site and an elective treatment center where you do the non-urgent stuff. Some hospitals have what we call an urgent care center. For example, minor traumas, some illnesses which can be treated and sent home. They don't need to be admitted. These are called urgent care centers. And more recently, they're developing community diagnostic hubs where some of the diagnosis can be done out of the main site. So these departments, which are being developed now actually, can have an MR, CT, ultrasound, X-rays, etc. Patients who don't need to come to the acute site, just for example, a cancer follow-up or cancer staging scan, or just a routine pain abdomen, etc. to confirm or exclude something. They go to this CDH, community diagnostic hubs, have the scan and go back home basically. So all these are various models which are being developed in the UK. So what sits in radiology and what do the departments have? Generally, a DGH or a district general hospital has all of these modalities, right? From plain films, fluoroscopy, ultrasound, CT and MR. We can have 2 CT or 3 CT machines. My department has 3 CT machines, for example. MRI, same with MRI. Depending on the work, we have multiple machines. Interventional radiology, most of these hospitals have interventional radiology. They may not be able to provide an on-call service, but they have a 5-day service at least. And finally, nuclear medicine. But one thing which we don't have in every hospital is PET CT, which is not so widely available, meaning not in every hospital. It is available, but not in every hospital. So probably, I would say 3 to 4 hospitals can have one PET CT. Coming to radiology staff itself, every department has a clinical lead or a head of the department, have a general manager who oversees the functioning and the rest of the staff. We have consultant radiologists and some middle grade doctors, we call them, who don't have their specialist registration or FRCR. We have trainee radiologists in most departments. Then the rest of the staff. So it's generally radiology is a big department in the hospital with more than 100 staff on average. Then coming to the working day itself, every consultant has an individual job plan, meaning your whole week is planned out. But we also have a departmental job plan, meaning what has to be covered in the department on a daily basis. And all this is based on service needs. So the job plan has to be flexible. Even though you have a job plan, you might have to move around depending on what the service needs. And in addition to your job plan, what you do on a day-to-day basis, you also have to supervise trainees and other members of staff as well. A working day normally made up of 2 sessions of 4 hours each, but sometimes you can have shorter sessions of 2 hours. For example, you can have 2 hours of CT reporting, 2 hours of MR reporting, etc. So this can be altered to suit individual needs and departmental needs. For example, someone might want to work 7 to 1, 6 hours and then take the afternoon off. That's possible because a working day is considered to be 7 a.m. to 7 p.m. But your working week is only 40 hours. So if you want, you can probably work 4 days and get a day off, but depends on the departmental needs and the agreement with the head of the department. Job plan varies each day of the week. It's not the same every day and usually covers a wide range of modalities. And most places do have a hot desk. What I mean by a hot desk is something which has to be covered every day. This is where normally a radiologist or a senior radiology trainee sits and answers all queries from the clinicians. If an urgent scan has to be done, this radiologist, he or she, will liaise with the CT or MR radiographers and get it organized, and basically answering all the queries from the hospital clinicians and also from outside the hospital as well, from primary care. If they have any doubts about radiology, they can bring this hot desk and we answer the queries. And the other sessions which have to be covered every day is A&D and inpatient reporting radiographs, inpatient ultrasounds, inpatient CT/MR, and obviously the interventional service, because we do have emergencies. So all these have to be covered. So minimum, there should be 5 radiologists on the ground, and the others will be reporting cold, meaning they report CT/MRs, do outpatient ultrasounds, etc. We also have multidisciplinary team meetings. These are tumor-specific MDTs. And these are all the common MDTs we have in most DGHs. Breast, lung, urology, upper GI, lower GI, skin, head and neck, hematology, gynecology, and I forgot dermatology as well there. So all these are tumor-specific MDTs held normally once a week. So all the cancers picked up in that week are discussed in these MDTs. And these MDTs, apart from those MDTs, we also have specialist MDTs in tertiary centers. So for example, hepatopancreaticobiliary cancer, anal cancers or NETs, neuroendocrine tumors, and some of the renal cancers and prostate cancers, all of these have been centralized. So they all go to the central MDTs, discussed there, and treated by specialists. So these cancers, for example, are not treated locally. And because of the numbers, I mean, the numbers can be quite low in the local centers. So they are all pulled up and done by specialist surgeons or specialist oncologists. So what does an MDT membership consist of? So we have normally an MDT chaired by a clinician normally. Then there's a non-clinical person coordinating the MDT, preparing the list, collecting all the information, and getting to the MDT. And the relevant clinical team is present. For example, the lower GI MDT, which I am part of, the colorectal surgeons are present in the MDT. They come every week to the MDT. As a radiologist, I attend the MDT with a colleague of mine. There's a pathologist with interest in colorectal cancers in the MDT, the oncologist. We have a cancer nurse specialist who looks after the patients pre and post treatment. There'll be a research nurse. If anyone is to be entered into trials, for example, the research nurse picks up those patients and encourages the patients to enter into the trials. Then if patients are in palliative care pathway, they can't be treated, but they have to be seen to have a more, what should I say, should receive palliative care. The palliative care nurse takes care of them. And we have other support services, for example, in the upper GI and head and neck MDTs, we have a dietitian who looks after that side of things. So it's quite a big team actually, and these are an essential core part of our day-to-day work. We have other department meetings like regular meetings, like monthly meetings, for example, like audit meetings, journal clubs, discrepancy meeting. This is very important because actually we have changed the name to real meetings, radiology errors and learning meetings. So any errors we pick up in the departments are pooled, anonymized, and we discuss these cases once a month. There's one of the radiologists takes on this role, presents the case, and we discuss the learning from these errors, a very crucial part of our practice. And obviously there'll be teaching as well and other meetings in the department. And we also have some key performance indicators, meaning turnaround times, we call them. All critical, life-threatening and major trauma cases are reported within 1 hour. Emergency cases within 4 hours. Any person admitted to the hospital should be scanned within 24 hours, etc. So all these are targets we need to achieve. We also have national diagnostic targets. I mean, all routine radiology examinations should be performed within 6 weeks, and 99% of these examinations should be performed within 6 weeks. And we also help with the cancer targets. I mean, 6 weeks is for routine outpatients, but for cancers, the target is less. It's actually 1 week now. We should scan all potential suspected cancer patients within 1 week. Basically, we have certain specific cancer targets. The patients are referred by the GP for suspected cancer, and the patient should have the initial investigations and come to a diagnosis within 14 days. Then following that, patient can have a biopsy or further tests, and by day 28, and it has to be submitted to the MDT, discussed in the MDT, and a decision made to treat the patient by day 28 of the initial referral. And following that, patient starts the treatment, and further few weeks are given for the first treatment to be completed. So all these are definite targets. Might look like quite a long time for you, because in India sometimes things can get quickly, but I tell you, it takes time to sort these things out properly, with the involvement of the MDTs as well, all evidence-based. And on all these, diagnostics play a very big role in these pathways. Now coming to the final part of my talk. How does the career in the UK look like? The National Health Service, it has its pros and cons, I agree. It's not a perfect system, but it is healthcare free at point of need. The most appropriate exam investigations are done. In other words, it's not financially driven. There's no financial motivation at all in the NHS. We follow clear guidelines from NICE and the clear pathways for patients. There's a good support system, and there is continued professional development. We have to undertake certain professional activities every year, and we have an appraisal every year to show that we're up to date. Only then we are signed off to continue into the next year. Clinical radiology is a well-respected and valued profession in the UK. That is why more and more young doctors are taking up radiology. In fact, clinicians depend a lot on radiologists and their advice. We can develop our own niche area or area of interest. You can choose what you want to do basically. There's so much demand for the specialty. And MDTs, a crucial part of our working week, is part of decision-making, patient management, and we're actively involved in that. We have a say in that actually. And in fact, we are probably the last generalist remaining. Everyone is becoming specialized more and more, and we are still a generalist. Then coming to the working pattern and support system we have. The digital systems throughout the UK, almost every department has PACS, RIS, Radiology Information System, and voice recognition. We all use voice recognition, so simple to use and quick. Electronic requesting, everything is requested electronically, and all the reports are transmitted back to the clinicians or the general practitioners electronically. Once you verify a report on your VR, it goes through to the clinician. And the imaging, okay, the patients can transfer between hospitals. So how does this system work? We have the image exchange portal, IEP. So images can be transferred across the country. And with the new network coming through, hopefully in the very near future, we'll have a common PACS across the network, and we can share images more easily. And Scotland, Wales, and Northern Ireland have a slightly unique system, a separate identifier system, and England has an NHS number. All people in England have an NHS number. And coming to the lifestyle, we have on-call as well, Monday to Friday. Once in every 3 weeks I'm on call, but until 9 only. And after that we also outsource the on-call. And weekends, when I'm on call once in 3 months, I work Saturday, Sunday, but after 5 o'clock in the evening, it's outsourced. It's quite a good lifestyle. We are busy, but also it's very organized and planned. There are lots of teaching and learning opportunities. As I said earlier, trainees rotate to the DJs, which forms the bulk of the radiology workforce. So we have trainees coming through, so we actually, it's very stimulating teaching them, and we learn as well in the process. We also teach medical and surgical junior doctors, present in the grand rounds, and also, as I mentioned earlier, the discrepancy of the real meetings is a good learning for all of us. And we also have trust audit meetings. All of us do audits. Most of us do at least one audit every year, not just trainees, but also us, to keep up to date and change practice as well. And also, it's a different system, different experience compared to, because I worked in India as well, so I know it's a different system. We have 6 weeks annual leave. In fact, as you become senior, we get more annual leave, more than 6 weeks per annum, which is quite a lot actually, because it's a 5-day week. In other words, we have 1.5 months of annual leave. In addition to this, we have another 2 weeks of study leave to attend conferences, and we get paid for that as well. It's a buyer's market. You can choose what you want to do and where you want to work. There's so many options and so many vacancies. Flexible working is an option, and more lately, since the pandemic, working from home at least 1 or 2 days a week is also an option, because we all have our own computers and workstations at home, which can access the trust workstations. And apart from your day-to-day work, you can get involved in teaching, academia, and research. You can become clinical supervisors for junior doctors, radiology trainees, or radiographers, in fact. This is remunerated. You can become the college tutor, Royal College of Radiologists tutor, helping with the teaching program for core trainees and registrars, liaising with the school and Department of Education, medical education, etc. You can also get involved in training junior doctors as well, and progress in a different career. I mean, not different, but what I mean to say, in the teaching career, taking up an associate dean or director of medical education post, and lots of research opportunities wherever you work. And within your organization, apart from radiology, you can also get involved in other management roles. You can become the departmental head or become a divisional director covering other areas in the hospital, and etc. You can move up the ladder. You can join other committees like research committees, the AI, digital board, etc. Lots of opportunities if you want to do other things out of radiology. And coming to outside the organization, you can become a member of your specialist organization. Every specialty has an organization. You have the Musculoskeletal Society, and you have the Thoracic, British Thoracic Society. You can become members of all those things. Join other radiology bodies. You're all members of the RCR. You'll become members of the RCR automatically because it's compulsory. You can also join the BIR, our organization. There are various special interest groups in the BIR. You can become a member of the ESR as well. So all this actually help you in a way, because it actually gives you more stimulation and keeps you going as well. Not just your day-to-day work, doing other things also stimulates you along the way. And there's more to life than just radiology. Have some downtime, which is possible because it's a 5-day working week here. Develop other interests and hobbies, so much available over here. Join your local clubs and organizations, and give some quality family time. Have that work-life balance. In other words, don't let work control you. You should be in control of the work. And just a few things to show you. The great universities in the UK, I mean, apart from the big universities like Oxford, Cambridge, you have the London universities, the King's College, Imperial, etc. Just a few slides from holidays, for example. You can have lovely holidays in the UK, and Europe is close by as well. And if you love sport, there's so much in UK. Summer is full of sport. UK people are sports mad. In fact, I always look forward to the summer. Wimbledon is one of my favorite hunting grounds. I tend to go almost every year, actually. Great place to be, great atmosphere. And who doesn't love cricket from India? And Lord's is a great place. And also you have your local cricket clubs. Every small village or town has a cricket club. And if you are a keen cricket fan or a player, they will be more than happy to welcome you there. So all in all, and finally, I can't not talk about the Premier League, very big in the world. I know that we have the IPL in India, but this is equally big here and even more, and it runs almost throughout the year. So all in all, you have lots and lots of other things to do apart from radiology. Yes, as long as you get used to the British weather, it's a great place to be. Thank you.